Hello everyone, glad to see you all. Let us have a recall of actinomycosis. Back to second year MBBS. 28-year-old man presented with pus draining sinuses in the right frontal scalp. He had a previous history of scalp injury due to road traffic accident 2 years ago. He underwent excision of indurated swellings and drainage of pus pocketing galea and periosteum. So these are the gross images. Patient was taken in the OT for drainage of the indurated swellings. And you can distinctly see these yellowish sulphur-like granules over the surfaces coming out from the draining sinuses.
These are the intraoperative images. This case was operated by the neurosurgeon Dr. Anirudh Mohiti from Kolhapur.
So in Shanti Pathology Lab, we received total 7 scalp tissue pieces, and over the surface there were numerous draining sinuses with fine yellowish granular material. After seeing this microscopic image, most of you must have gone down the memory lane to your second MBBS, where this slide is kept as a spot diagnosis slide in the practical exam. So this slide shows acute suppurative inflammation with an embedded ray fungus or actinomycosis, which are slender, filamentous, fungal-like organisms. The other foci showed multinucleated giant cells, macrophages, lymphocytes, and some plasma cells. So we rendered a diagnosis of actinomycosis from the excised tissue of the right frontal scalp region. So let us have a short history of actinomycosis. Bollinger in 1877 found a mold-like organism in the lesion of a lumpy jaw in the cattle. Actinomyces terminology was coined by Haars due to ray-like appearance of the organism in the granules. Actinomyces means ray fungus. Later in 1891, Wolf and Israel isolated an anaerobic bacillus in the human lesion. This was named after him as Actinomyces israeli, that causes human actinomycosis, and Actinomycosis bovis is found in the cattle. Actinomyces are gram-positive genus containing over 40 species. Actinomycetes are thin, gram-positive, non-motile, non-sporing, non-capsulated filaments that break up into bacillary and coccoid elements. And this lies somewhere between the bacteria and the fungus. The actinomycetes are anaerobic and aerobic. Under the anaerobic comes anaerobic actinomyces, arachnia, Bifidobacterium rothia. The major pathogenic genus is anaerobic actinomyces, and these are non-acid fast. Now these need to be differentiated from the aerobic ones. The most common is nocardia, and this may be acid fast. The others are actinomadura, dermatophilus, and streptomyces. Actinomycosis occurs throughout the world, but its incidence in the developed countries has been declining, probably due to widespread use of the antibiotics. It is more common in the rural areas and agricultural workers. This is an endogenous infection often found in immunocompromised individuals. It causes chronic granulomatous infections in human beings and animals. It is characterized by development of indurated swellings, mainly in the connective tissue, leading to suppuration, discharge of sulphur granules through the abscesses. The lesion often points towards the skin, leading to multiple sinuses. Actinomyces is present as in commensal in the mouth, intestine, and vagina. Trauma, foreign body, or poor hygiene may favor tissue invasion. Actinomyces israeli is the most common causative agent. Now, actinomycosis is usually found as a mixed infection accompanied by other associated bacteria, which may enhance the pathogenic effect. There are four main clinical forms. The most common is orocervicofacial, which is about more than 50% of actinomycosis infection. These lesions are indurated lesions over the cheek and the submaxillary regions. It is caused due to poor oral hygiene, leading to gingivitis and periodontitis. Under the disseminated forms comes the thoracic. These lesions are found in the lungs, could be due to aspiration of food or foreign body. These lesions may involve the pleura and the pericardium and spread outwards towards the chest wall. 20% lesions are found in the abdominal cavities, usually around the cecum involving the neighboring tissues. Appendicitis, diverticulitis, or post-surgery such as cholecystectomy, colectomy may also lead to actinomycosis. Sometimes the infection spreads to the liver via portal vein. Pelvic actinomycosis is common in the women with the use of intrauterine devices. It may also be found in the central nervous system. Laboratory diagnosis. The specimen obtained is pus or tissue. In the pulmonary disease, it is sputum. Now, grossly, the sulphur granules are taken in saline. These granules are white or yellowish, ranging from specks to about 5 mm. These granules are taken over a slide and crushed with help of another slide, and the gram staining is done. Now, these granules are bacterial colonies and consist of dense network of thin gram-positive filaments surrounded by peripheral zone of radiating club-shaped structures with ray appearance, hence the name ray fungus. Culture. Granules are inoculated on thioglycolate liquid medium or streaked on brain heart infusion agar and incubated anaerobically at 37 degrees. A. bovis shows general turbidity, whereas Actinomyces israeli grows as fluffy balls at the bottom of the tube, and spidery white irregular or smooth colonies may be noted on solid media after 10 to 12 days. Species identification is done on gel diffusion and immunofluorescence. Treatment. Indurated swellings can be surgically excised and the patient is put on long-term antibiotics, and the duration may range from several months or even longer. Now, the antibiotics given could be penicillin, amoxicillin, erythromycin, tetracycline. I hope you found this unusual case of actinomycosis involving the scalp interesting. Do like and subscribe my channel and also share it with your friends and colleagues. If you have any comments, please note it down in the comment box. Thank you very much.